Hey everyone, thanks for tuning in. Today we're going to talk about how to read an EKG. And I think one of the most important things you can do when you're reading an EKG is to use the exact same method every single time, to have an approach that you use so you don't miss anything. And I'm going to share my approach with you. So every time I read an EKG, I look at the rate, rhythm, axis, intervals, hypertrophy, and then ischemia. And I save ischemia for last on purpose, because it is, of course, one of the most important things we're looking for, but we don't want to miss all of the other things as well. So let's jump in. The first thing I look at is the rate. And I think a lot of medical students are taught how to read all of the QRS complexes in a 10-second EKG, multiply them by 6, and boom, you get a pretty accurate rate. But the approach that I use that I feel like is a little bit faster is actually counting the number of big boxes between every QRS. And I call this the 300, 150, 100, 75, 60 method, which is totally a mouthful, but I think it works pretty quickly, and I'll go through how it works. So basically a standard EKG, it goes at 25 millimeters per second. So each second will have 25 small boxes, which accounts to 5 big boxes. For each minute, there's going to be 300 big boxes, which means if you have a heart rate at every big box, you're going to have a rate of 300 beats per minute. If you have 2 boxes between each QRS, that will mean you have a rate of 150. 300 divided by 3 big boxes is a rate of 100, and so on. Of course, this method is only accurate if your rhythm is regular, which we can talk about next, but it gives you a pretty quick overall gestalt on if the rate is fast or slow. And so I like it a little bit better than counting all of them up. And the next thing I look at is the rhythm, and we could literally spend hours talking about how to interpret rhythms, but really what I want to just touch on is how to determine if it's sinus or not. So of course, you'll need a P wave for every QRS, but I also look at the direction of the P wave to answer the question of where in the atria is that P wave coming from. And if it's coming from the SA node, which is in kind of the higher side of the right atrium, then your P wave should be positive in 2 and negative in AVR. If it's not, then you know you probably have an ectopic P wave. And in this section, you should also be looking for extra beats, like PVCs or PACs. And so a PVC, what is it? It's a premature ventricular contraction, which means the depolarization is coming from the ventricle itself, which means there's not going to be a P wave before it. If you're not going through the AV node, then you're going to have a Y depolarization. A PAC, a premature atrial contraction, is when you have a P wave that's coming from somewhere other than the SA node that's causing electricity that's depolarizing through the AV node. So you're going to have a P wave, but it's going to be different from the sinus node. So if you look at your direction or your kind of morphology of the P wave, it will be different. And the early QRS complex will be narrow. And after these complexes, usually the sinus node is depolarized. And so it takes a moment for the SA node to reset. And so you'll see a non-compensatory pause after a PAC. So that's kind of how you can distinguish between the two. The next thing I'll do is look at axis. And as you can see, a normal axis should be positive in 1 and 2. If it's negative in 2, that reveals a left axis deviation. If it's negative in 1, that reveals a right axis deviation. Some people also use the thumb rule where their left thumb is 1 and their right thumb is 2, and whichever thumb is up reveals which axis deviation it is. So if it's negative in 2, your second hand, then it's a left axis deviation. My left hand is up. And if it's negative in 1, your first thumb goes down, then it's a right, 2, up, right axis deviation. That doesn't actually work for me because it doesn't help me to think about the vector of electricity, but it's fast, and if you memorize it, then it works for folks. Once we figure out the axis, I look at intervals, and for brevity, we're just going to go over the normal intervals for each of these. So the PR interval should be less than 200 milliseconds, which is 1 big box. Then I look at the QRS complex, which should be less than 100 milliseconds, and that's about 2.5 boxes, where a block is defined by a QRS complex that's greater than 120 milliseconds, or 3 small boxes. Then I look at the QT interval, which will change depending on the speed of the heart rate. So most folks will look at the QTC, or the QT interval corrected, which is the QT interval divided by the square root of the RR interval. But a general rule that I sort of think about is if the T wave terminates about halfway between the QRS complexes, then it's probably not prolonged. And I think about a QTC, anything over 500 is typically prolonged, and that's when you want to be mindful about medications that can prolong the QT interval, since that will increase the person's risk for torsades. All right, next thing I look at is hypertrophy. So first I look for left ventricular hypertrophy, and there's two different ways you can do this. The first method I look at is by counting up the biggest S wave in V1 or V2, whichever one's bigger, and looking at the R wave in V5 or V6, again, whichever one's bigger. You add up the S wave and R wave heights, and if it's greater than 35 millimeters, then you have left ventricular hypertrophy. Another criteria you can use is by looking at the R wave in AVL, and if it's greater than 11 millimeters, that also indicates left ventricular hypertrophy. And the next thing I look at is left atrial enlargement, and you can see that if your P wave is biphasic in V1, with the second half of the P wave being larger than 1 by 1 millimeter. Then I look at right ventricular enlargement, and you can see this if someone has a right axis deviation, as well as the R wave being bigger than the S wave in V1. And then I look at right atrial enlargement, and I can see that if my P wave is higher than 2.5 boxes in the inferior lead, so 2, 3 in AVF, or if it's taller than 1.5 boxes in V1 or V2. All right, finally, we get to looking for ischemia. Again, the most important thing we look for, and we save it for last so we don't miss anything else. I find it's helpful to do this in a territory-directed manner as well. So you're really thinking about which vessels could be affected when you do identify signs of ischemia. And in this section, we're looking for Q waves, so anything bigger than a half a box. And then we also look for, of course, ST elevations, depressions, which is early ischemia, or T wave inversions. All right, so let's go through the territories. The first I look at is inferior, so that's in 2, 3 in AVF, and that's typically indicating the right coronary artery or the left circumflex. Then we look at the lateral territory, which we can see in 1 in AVL, and that indicates the left circumflex. Then we look at the septum, which is seen in V1 and V2, usually the proximal LAD. Then we look at the anterior leads, V3 and V4, which also shows the LAD. Then we look at the apex of the heart, also kind of terminal lateral leads, which is V5 and V6. And that's usually looking at the distal LAD, the distal left circumflex, or the right coronary artery. And in this section, you can also look for R wave progression, where the RS complex in V1 eventually transitions into being a QR complex in lead 6. And the transition zone, where the S wave and the R wave are about the same, usually should be around V4 or V3. And if it's not around there, then that can also be an indicator of ischemia. And then finally, of course, we don't want to forget about the left main, and we see that in AVR. All right, the last thing too to keep in mind is if you do find a left bundle branch block that's new, you should probably consider that being an ischemic presentation until proven otherwise. And that's really it. I think it's just really important to develop this approach and stick to it so your eyes develop a muscle memory of where to look over time. And start by repeating this method over and over on the EKGs that you order on your patients. And a really great resource to use for additional practice is Wave Maven, and it was developed at Harvard, and it has a great testing method where you can look at clinical vignette and tie it to the EKG and sort of kind of predict what's going on. And it's also divided up by difficulty. And that's really how what I use to develop my approach. So again, get your rhythm down, rate, rhythm, axis, intervals, hypertrophy, ischemia every single time. All right, well, best of luck to you, and I hope you have some fun reading some EKGs.